In this lecture, we are going to cover the final chapter in our textbook, which is chapter number 25, and we're going to talk about cognitive behavior modification. Now, most of this semester, we have focused on behavior modification as it applies to analyzing and modifying overt behaviors. And we even spent quite a bit of time at the very beginning of the semester talking about the difference between overt or external and observable by others behaviors, and covert behaviors, behaviors that are more internal and only observable or noticeable by the person who is doing those behaviors. This chapter's topic, these cognitive behaviors, fall under the category of covert behaviors. These are going to be things that occur internally and that aren't as easily observed and recorded by others. So as you might have guessed, the definitions here are a little bit contentious. Some people don't even consider covert behaviors to be behaviors. Some people only consider overt behaviors to fall under the definition of behavior, and the word cognitive tends to bring in its own bout of contention, where a lot of individuals don't like using that word because it implies thought. So just keep in mind that this definition and this specific usage isn't everyone's cup of tea. But the textbook does a very good job outlining how the authors of our text choose to use that term and how some others choose to use that term and what they mean by it. So if you're looking at the literature and they start talking about things like cognitive behaviors or something like that, they should always give an indication of what they mean by that term, because as we've seen previously with a lot of other terms, not every researcher is going to be using the same term in the same way. There aren't standardized definitions and usages, so there's going to be a different operational definition for each study that you look at. So our definition from the textbook for cognitive behavior is going to be behavior that involves self-talk or imaginal responses. So these are things that are covert, things that are happening within that individual's mind. So self-talk or imaginal covert behaviors would be something like speaking to yourself in your head. Maybe you tell yourself, "Oh, you're looking really good today." That would be self-talk. Imaginal behavior would be something like thinking of something inside your mind, maybe imagining being on vacation and sitting on a beach. That would be something that falls under this definition that we're using of a cognitive behavior. So by thinking about those things, you are working through a cognitive behavior. You might also see these called private events because they are occurring covertly. And our textbook makes the point that they will sort of, for shorthand, instead of continually saying a cognitive behavior or imaginal behavior or self-talk or something like that, they'll use the shorthand of thinking with sort of that imaginal asterisk of thinking is its own difficult word that not everyone agrees to the use of. And I suppose it goes without saying that when we're talking about cognitive behavior, we're going to be pretty much exclusively talking about it in terms of human cognitive behavior, because anything to do with non-human animals and cognitive behavior is its own can of worms. So, enough disclaimers on that. Let's move on to talking about public versus private events, because I just mentioned that a cognitive behavior would count as a private event. So a private event is a behavior that's only observable to the person who is emitting it. We can also call it a covert behavior. We can call it a cognitive behavior because of the way that we've defined all of these terms for our use here. So this is just saying that the things that we think about, the things that are occurring within our minds are private, that we are the only ones who know what we're thinking. Someone looking on doesn't know what you're thinking, so they can't observe and record and sort of know what's happening within your mind. And we can make the clarification that all of the sort of cognitive behaviors, these covert behaviors that we're talking about, things that occur internally within our minds, would classify as private events. But private events can also be other things. The two terms aren't mutually exclusive. So a private event, from this definition at the top, where it's a behavior that's observable only to the person who emits it, that would also count for something like if you sneeze and nobody's around. You are the only person that knows about that event because you emitted it. So it would count as a private event, but it isn't an internal or covert behavior. So not all private events count as covert behaviors or cognitive behaviors, but all covert or cognitive behaviors would fall under the category of private events based on what they are. Okay. So, as a contrast, we can talk about a public event, which is defined here as a behavior that is observable by a person other than the one engaging in the behavior. So, if a researcher can observe and record and make note of and measure that behavior, then it's a public event. This would also count as an overt behavior, something that is external, something that is observable. And because these are overt and observable, they can be verified by scientific methods, whereas private events, just by their nature, cannot be. In order to be verified by scientific methods, there needs to be something to observe, to measure, and to quantify. So our private events, again, by their nature, don't allow for that. So just something to keep in mind when we're using these concepts. All right, now that we have set the stage and we kind of know some of the concepts that we're going to be talking through, we are going to start talking about actual cognitive behavior in clinical problems. So how do we actually go about treating and modifying cognitive behaviors? Now, there's going to be a little bit of overlap with some of the other topics that we've talked about so far. So we can talk about behavioral excess or deficit. This time, we're just referring to cognitive behavioral excess or deficit. So we can have problems, so examples of problems involving cognitive behavioral excess, where we have too much of a behavior happening. Maybe depression, if we frame it as stemming from negative self-evaluations. There is too much negative self-talk going on that can lead to depression. Obsessions and ruminations are going over and over and over the same idea, the same thought, so that's an excess. Fears and phobias are a sort of blown up response to a stimulus that doesn't or that shouldn't elicit that kind of response. Same with worry. So these are all problems because they are too much. We can also have problems involving cognitive behavioral deficits where there is not enough happening. So we could frame impulsivity as lacking in thinking. If you're not thinking enough about the consequences of an action, that can lead to impulsivity. Deficits could involve poor decision making or poor problem solving, again, because you're not thinking enough about the situation. There is a deficit in cognitive behaviors. So in clinical settings, you can try and decrease these things that come from excesses, and you can try and increase the problems that are driven by deficits. So you can try and adjust what we're lacking or what we have too much of to try and achieve a more balanced situation. When you get started with this cognitive behavior modification, you of course need to define the cognitive behaviors that you are targeting. You have to identify the occurrence of specific thoughts and images. So the client needs to know exactly what kind of thoughts, exactly what kinds of images that they should be watching out for so that they can identify them and record when they happen. So these have to be very specific behaviors. You can't just use labels for the behavior. So we have the example at the bottom here of we might talk about someone as having low self-esteem or displaying low self-esteem. but that isn't a specific behavior. That's a label for a cluster or a large grouping of a bunch of different behaviors that can fall under that category. So low self-esteem can include cognitive behaviors like thinking, I'm no good, I can't do anything right, nobody likes me, or images of yourself failing. Those specific behaviors that you want to identify all fall under the category or the label of low self-esteem, but we want a more specific set of cognitive behaviors that we want our clients to be on the lookout for. We could also look at something like self-confidence, where this is sort of a more positive cognitive behavior. So you can say, I can hit this pitcher, which I assume means that you can hit the ball thrown by this pitcher. Otherwise, your self-confidence is a little bit extreme there. You might say to yourself, I'm better than he is, I'm going to win this game, images of success. So we can define these different cognitive behaviors, and these groupings of cognitive behaviors can all fall under a common label for the behaviors. So these cognitive behaviors are all indicators or all related to having low self-esteem, if that helps clarify. So if I'm spending this much time to stress that we need to focus on the cognitive behaviors, these specific behaviors, and not the labels, one of the major reasons why we sort of shy away from just using these labels is this issue of circular reasoning. So if you've ever heard the term circular reasoning before, it's a situation in which there are a couple of different arguments. Usually the example shown is there are two arguments, and the two arguments kind of lead into one another. So the diagram that I usually see looks something like we have argument A at the top. So maybe we have the situation of the observed behavior is given a label. Oh, it's low self-esteem. Well, there we go. Put in argument B and a directional arrow. There we go. From our examples on the previous page, we might have this sort of cognitive behavior of nobody likes me. So if we call that low self-esteem, we can say that that behavior of thinking that nobody likes you is because of low self-esteem. That's low, or we can say that that is low self-esteem. Well, this person has low self-esteem. Then we can use the label as the explanation for that behavior. Well, they think that nobody likes them because they have low self-esteem. And they have low self-esteem because they think that nobody likes them. And so you can cycle through these two sort of arguments that on their own seem like, yeah, we're explaining this behavior, this negative thought is explained by the label of low self-esteem, but we're not actually explaining anything. We're just sort of talking ourselves in circles. Another example. So there's a kid who doesn't want to talk with the other kids, so he's labeled as shy. But being shy is then used as the explanation for why he doesn't talk to people. So he's labeled as shy because he doesn't want to talk, and then he's explaining, or that behavior is then explained away by the label that it was just given. So the problem with this circular reasoning is that the label is simply a name for the behavior. We've just sort of named it, we've fit it into a category, but it can't be the cause or the explanation for that behavior. So it can't serve both purposes. The causes of those behaviors have to be found in the environment. So you can't just rely on those labels alone as the explanation, they're just a descriptor. Now, before we move on to actual types of cognitive behavior modification, we're going to talk very, very briefly about some of the functions that cognitive behaviors can fulfill. So a thought or image, one of our cognitive behaviors, can function as a conditioned stimulus. So a thought can make somebody feel angry or anxious or excited. So just thinking about something or imagining something can elicit some kind of response. So it can lead to other behaviors happening. A thought or image can also function as an establishing operation. If you frame a situation in a positive way, then you might be more likely to do a behavior. If you frame a situation in a negative way, you might be less likely to do that behavior. So your thinking, your thoughts, and internal images can adjust what you are framing that environment as. Thought or image can also function as a discriminative stimulus for other operant behaviors. So different types of thoughts like self-instructions or problem solving or internal decision making can lead you to successfully complete another behavior. So self-instruction, if inside your head you tell yourself, okay, just do A, then B, then C, that can serve as a discriminative stimulus for you to actually go out and do A, then B, then C. So it can lead to you performing those behaviors. And lastly, a thought or image can also function as either a reinforcer or punisher. So if you use something like self-praise, after you've completed a behavior, if you tell yourself that you did a good job, that's going to act as a conditioned reinforcer. You're going to make yourself feel better. Or maybe you're going to criticize yourself after you've completed a behavior. That would serve as a punisher. So these thoughts and images, these cognitive behaviors can serve a variety of functions, just like we're seeing here. All right, so let's move on to actual modification techniques. So we're going to talk about types of cognitive behavior modification, or sometimes called cognitive behavior therapy. I am more familiar with seeing it called cognitive behavior therapy, or CBT. And we're going to talk about two of the most common sort of broad categories of cognitive behavior therapies. These are cognitive restructuring and cognitive coping skills. And I suppose I should state that cognitive behavior modification is simply a procedure that we're using to help people change those cognitive behaviors. Just like behavior modification describes techniques that are used to adjust behaviors. We've just stuck cognitive in front of it to quantify the fact that these are internal covert behaviors as opposed to the external overt behaviors that we've been talking about throughout the course up to this point. Okay, just in case that wasn't clear. So let's start with cognitive restructuring. So for cognitive restructuring, the goal here is to replace distressing thoughts with more desirable, rational, or functional thoughts. So this is usually an instance of trying to decrease the occurrence of bad thoughts or negative thoughts or irrational thoughts that are interfering with normal functioning. So this would occur if you had an excess of some kind of cognitive behaviors. So maybe we're trying to deal with people who are experiencing extreme anxiety, maybe OCD or something like that, where they have repetitive, invasive thoughts that aren't helpful. So the goal would be to replace those distressing thoughts with something that is more conducive to living a life uninterrupted or even less interrupted by those invasive thoughts. So the basic steps of this cognitive restructuring, of course, start off with identifying the problem. So identify the distressing thoughts and the situations where those thoughts occur. There are two major ways that you can do this. You can use a retrospective self-report or self-monitoring. And so a retrospective self-report would be asking you to sit down and think about what kinds of thoughts do you remember having. So retrospective because you're being asked to reflect back on things that you experienced in the past. And it's a self-report because you're the only person that knows your own thoughts. So you would need to report what you remember thinking. Of course, there's some problems with that because you're relying on an individual's memory, you're relying on them to remember when it happened, what you were specifically thinking, and so on and so forth. So you have to accept that that might not be the most accurate form of monitoring this behavior or figuring out when this behavior occurs, but sometimes that's all that's available. You could use something like self-monitoring, so having someone carry around, say, a voice recorder or a notebook, so that whenever they have these distressing thoughts, they can write down the time, the date, and the nature of the thought that they're having. So that's a little bit more accurate, it gives you more information, but again, it has drawbacks because you're then required to constantly have this source of recording with you, and it's a lot more intensive. So both techniques can be used to try and identify these thoughts and when they occur, and it sort of just depends on what situation it is, what behaviors you're looking at, and what the client is capable of doing. Our next step is to identify the emotional response, mood, or behavior that follows. So once those distressing thoughts have happened, what comes next? So again, we can use self-report or self-monitoring, just like in step 1, but this time we're getting the client to focus on what comes after you've had those distressing thoughts. And the point here is to get them to focus on the fact that these distressing thoughts usually lead to a very negative emotional response, a poor mood, or bad behaviors. So we're trying to make that connection more plain that these distressing thoughts actually lead to bad things, so that we can frame it as getting rid of these distressing thoughts is good. And it helps make it more likely that the client will move away from having those distressing thoughts because we'd like them to stop having these negative responses, emotions, moods, behaviors, whatever. Once we've established that framework, we can move on to step 3, which is to help the client replace the distressing thoughts with more rational thoughts. Now, this sounds fairly simple on paper, but as you can imagine, it's going to be a lot more complicated than just saying, poof, just think of something else, or just don't think that distressing thing. You're instead going to have to try and challenge their distorted or irrational thinking to try and get them to think more rational thoughts. So we can talk very briefly about how you might actually challenge this. And the textbook does a good job noting that if you directly tell the client that their irrational thoughts or their distorted thoughts are wrong, you might actually not do any good and you might really cause harm. Oh, and I actually have a slide for this. So don't just tell them what they should be thinking. If you just tell them what you think they should be thinking, that can lead them to resist that push. That can lead them to sort of resent your insertion into their thoughts. The clients won't think differently just because you've told them to think differently. Instead, what you have to do is present other information or get them to think about things critically so that they themselves can start challenging their own distorted or irrational thinking. So if we go back to the earlier slide, we want the clients to start questioning how logical or rational their thoughts or beliefs are. And in brackets, there are 2 names, Ellis and Beck. These are from some examples in the textbook. I would highly recommend reading through those examples. It just really helps illustrate these points. And they're fairly straightforward, so I'm not going to go over them again here. We're just going to talk in sort of theoretical terms here. But you want to ask, it kind of boils down to 3 basic types of questions. There are, of course, numerous variants on these, but whenever somebody displays some kind of distorted or irrational thinking, you want to ask them something along the lines of, where is the evidence for that thought? So if somebody says, nobody likes me, you can say, okay, well, where's the evidence for that? What makes you think that nobody likes you? What kind of support do you have for that statement? And if they can't come up with any good evidence for that statement, it can start to lead to them questioning the validity of that thought. You might ask the client something about alternative explanations. So you might say, okay, is it that nobody likes you, or is there something else going on? What else might be going on? So by getting them to consider the existence of alternative explanations, they might realize that there is a less distorted explanation for their thoughts, or for the situation, and it can help them change their thoughts. You can also ask, what are the implications of this thought? So if you think that nobody likes you, well, what does that mean? So if nobody likes you, then nobody will ever speak to you. But maybe people do speak to you. So you're kind of using these questions to guide the client to a point where they realize that their logic or rationale isn't quite logical or rational. So you're getting them to realize that the thoughts that they're having are actually distorted or irrational thoughts, and that they should change how they're framing the situation. They should adjust how they're thinking. But again, you can't do it directly. You can't just say, well, stop thinking silly things or whatever. You want to tell them, or you want to sort of guide them to coming to that realization and adjusting their own thoughts in their own way. Now, this slide includes a bunch of very common cognitive distortions. So these are just biased ways of thinking or irrational ways of thinking that a lot of individuals will commonly have. So you can see the idea of all or nothing thinking. This could be the idea that things are just black and white, or black or white, where it has to be one way or entirely the other way. There's no gray area. There's nothing in between. It's all or nothing. So if you and a friend get into an argument, because you're fighting, you might think that, oh, we've argued, therefore we're now enemies. There's no room in all or nothing thinking for the idea that you can still be friends, you just had a disagreement. With that cognitive distortion, you would view it as either we are friends and we never fight, or we're enemies and we fight. So that's one of the distortions. Overgeneralization is another. This would be when a single event occurs and you apply that event to a whole bunch of other situations. You generalize to other situations. So you might view a single negative event in your life as evidence that everything will be bad from then on. Some individuals disqualify the positive, or they'll downplay the effect of positive events and choose to focus on the negatives. Things like jumping to conclusions can also count as a cognitive distortion, where you can ignore some evidence to just get to a conclusion, and once you've jumped to that conclusion, you discount or ignore any other evidence that is presented. Things like magnification and minimization kind of relate to that, where you can magnify or over-focus on some aspects and minimize or under-focus on other aspects. That can again lead to biased conclusions. We talked already about labeling and mislabeling. This could be as simple as deciding that a situation is bad, but maybe you've just framed it as bad and the situation was neutral, or maybe even positive for you. But because you've labeled it as bad, you're now going to treat it as a bad situation. And the last being personalization. This would be the assumption that bad events are coming from you. You are the cause of these negative events, even if there is no evidence that you are responsible for those bad things happening. So these are a subset of possible cognitive distortions that you might see in individuals that are displaying disordered thinking or irrational thinking. On this slide, we're going to start talking about the steps involved in cognitive therapy for depression. Now, cognitive therapy is a variation of cognitive restructuring. It's one of the most common variations of cognitive restructuring. So it's going to be a process that also includes cognitive restructuring, but also includes other aspects as well. So if we're going to look at specifically using cognitive therapy to treat depression, we can see how this compares to our steps for simply using cognitive restructuring. So step 1 is to use an activity logbook to look at behavior and mood, which looks a lot like one of our early steps here, where we're identifying the distressing thoughts and situations where they occur. Where our cognitive therapy starts differing from just normal cognitive restructuring is where we start using behavioral assignments to increase activity level and access to reinforcers. Now, this comes from the fact that many individuals with depression end up having lowered levels of activity. And because they're doing less, they're being less active, they also end up having less access to reinforcers. So if you introduce a mechanism to increase those activity levels, to actually give them access to those reinforcers, you can help introduce sort of more positive aspects to their lives. Step 3 involves assessing the relationship between the activities and mood. So the hope here would be that you want to find that increased activity levels leads to an increase in mood. Otherwise, you might have to go back and find different activities that help increase mood. Then you want to start assessing cognitive behavior. So you want to specifically track what kinds of thoughts or specifically distorted thoughts are the individuals displaying. So someone who is experiencing depression might be having thoughts along the lines of, I'm worthless, I'm helpless, or something like that. So you would want to track, maybe in the same logbook, when those behaviors are occurring or when those thoughts are occurring. We, of course, want to find the relationship between those cognitive behaviors and mood. Usually you're going to find more negative cognitive behaviors when you're in a worse mood. So the more upset someone is or the more depressed someone is feeling, the more they're going to exhibit those negatively framed cognitive behaviors or thoughts. And if you find that there's a relationship here, you can move on to cognitive restructuring. So this is when you would use those negative or distorted cognitive behaviors. You'll then move on to drawing the client's attention to the fact that those negative thoughts or those distorted thoughts usually lead to sort of negative behaviors, negative emotions, bad things in general. And then you can start encouraging them to replace those negative or distorted thoughts with more rational or logical thinking. Our last step here is the same as what we've seen with a bunch of our different training steps, where at the beginning you might have the client working directly with a therapist or some other kind of change agent, but at the end you want to bring the control back to just the client by themselves. So the last step is to transfer those skills from something that the client and their change agent do together to something that the client can do on their own. So once they've learned to start replacing their negative self-talk with more positive thoughts, then they can start doing that on their own and they don't need someone else around to help them sort of replace those thoughts. And that is as much as we're going to talk about cognitive restructuring. As per usual, I'm sure you can tell that there is so much more that we could talk about in terms of cognitive restructuring and even variants upon cognitive restructuring, but we get one chapter at the very end of this textbook, so that's all we're covering today. Just more making you aware of the existence of these topics that you might want to study in the future if this is something you want to pursue. But what we're going to do is move on and talk about cognitive coping skills training. Now, where our cognitive restructuring is usually used to try and deal with problems where there is an excess of cognitive behaviors, where we want to reduce some of those negative thoughts or negative situations, for cognitive coping skills training, we're doing the opposite. These are usually intended to help increase things that are in deficit. So if we don't have enough thinking, if we don't have enough critical evaluation, we can use cognitive coping skills training. And there are 3 types of cognitive coping skills training that we're going to talk about, again, very, very briefly. There is self-instructional training, stress inoculation training, and problem-solving training. The textbook focuses mostly on the first one here, so that's what we'll cover in the most detail. But let's start there with self-instructional training. As you might imagine from the title, self-instructional training is a method of training clients to use self-instruction to help increase the occurrence of cognitive behaviors that are existing in deficit. So if you're not doing a behavior enough, you can use self-instruction to do it more often. So our steps, we break them down into 4 basic steps here. You start off, of course, identifying your problem situation and your desirable behavior. So what isn't happening enough? What do you want to happen more? What do you want to change? This would also be a good step to figure out if there's anything else going on that's interfering with the occurrence of your desirable behavior. That should all happen in step 1, where you're basically framing your problem. What is a problem, and what do you want to change, and how are we going to start changing it? Next, we want to identify the self-instructions that you want to use in the situation. If you want to start increasing, maybe somebody wants to start increasing their self-confidence. So they want to use self-instructions like keep your chin up, straighten your posture, smile, things so that they can start acting more self-confident, maybe hoping to feel more self-confident. So they can identify self-instructions, things they can tell themselves to do that would help achieve that desirable behavior. Then you're going to implement behavioral skills training to teach the self-instructions. This is basically where the client learns to say those self-instructions that we've decided on, and then they immediately carry out the desirable behavior. So if they're telling themselves to smile, keep their chin up, and straighten their posture, then once they've told themselves to do that in their mind, then they should immediately do that. Once they've learned to tell themselves to do these things and to actually then do those desirable behaviors, they then bring everything together and they start identifying when a problem situation has arisen. Maybe they're starting to show some behaviors associated with low self-esteem, so they should identify when that's happening. They should then start giving them their self-instructions within that problem situation, and they should use it to guide their desirable behavior. We can also briefly touch on stress inoculation training and problem-solving training, even though these aren't covered too much in the textbook. But our steps here are going to be fairly similar as they've been throughout this chapter and other chapters. Start by identifying or framing the situation. So here we're going to identify self-statements that contribute to stress or anxiety and the situations in which they occur. So if people are having negative self-statements that are causing them stress or anxiety, we want to figure out what those statements are and when those individuals tend to have those occur. So if somebody tells themselves that they are worthless, when does that happen? What situations precipitate that? Step 2 here is a little bit different, where we're going to start generating new coping self-statements to be used in 4 phases. The first phase is preparing for the stressor. So these situations that will lead to the negative self-statements we talked about earlier on, confronting that stressor. So the first step is sort of just being aware that that stressor can occur. Then when it occurs, you're going to confront it. Then you're going to give yourself statements that help when you are feeling overwhelmed by that stressor, and then praising yourself for coping with the stressor. So maybe a child is doing very poorly in a math class, and doing poorly in that class, getting the questions wrong, makes them feel worthless. So we can have them preparing to go to math class, telling themselves that you can do this, you can go to class, confronting the stressor, they're in class, you're doing it, you're going to be fine. Being overwhelmed by the stressor, maybe they get a question wrong. It's okay, you'll get the next one. And then praise for coping with the stressor is when they've done when they finish the class, they come out the other side and say, you did a great job, you finished the class. So these are all self-statements, things that they're telling themselves, sort of encouraging them to continue going to class and doing well and not feeling overwhelmed by that feeling of stress or anxiety that would have come from being in that class. So I just walked through actually employing these, but we were talking about generating the statements that could be used at each of these stages. Then you would want to rehearse those statements in role plays. So, thinking about being in those difficult situations, thinking about going to math class, and then practicing in progressively more stressful situations. So, sounding a little bit like extinction here, where you work your way up to actually using those self-statements in a math class. So that is very, very, very briefly stress inoculation training. And then the last one is problem-solving training. This is a specialized type of training that basically sets you up to want to solve problems. A lot of individuals encounter problems, and instead of dealing with them and the potential stress that might come from trying to solve a difficult problem, they might just avoid problems. So problem-solving training is specifically intended to get people to approach these problems, decide to actually solve them, and then have a series of steps that help them to solve those problems. So step 1 is developing a problem-solving orientation. Basically decide that you want to solve this problem. Step 2 is to define the problem that you're going to be solving. Step 3, generate possible solutions through brainstorming. Think about the problem and how you might solve it. Evaluate the potential solutions that you've generated, and then put the plan into action and evaluate how it works. This training category is a lot more specific to a very specific type of problems with problem solving, but since the textbook mentioned it, I figured I would include it again very, very briefly here. And this brings us to our wrap-up for this chapter and for the course. From everything that we've walked through throughout this class, we've kind of gotten to this idea that many things that are framed as mental health issues can be broken down and understood fundamentally as behavioral problems. So a lot of things that might be presented as more complex and more difficult and more all-encompassing, if we frame it properly and if we look at our sort of antecedent behaviors, the behavior itself and what follows, we can break these things down into somewhat more manageable chunks. That being said, it doesn't mean that all mental health framed issues are easily solvable through behavior modification. In fact, having gone through all of the different processes and all of the different methodologies and ways of modifying behavior, we tend to come out the other side realizing that, yes, we can frame things in different ways, we can propose solutions, but going from understanding that there could be a solution to enacting that solution is not always the easiest. This coming from someone who does research on and teaches in the field of learning and behavior modification, and has yet to teach her birds to behave or do tricks or anything like that. So knowledge doesn't equal immediate outcomes. But that's, I suppose, a whole rant that I could go on my own. I should move on to point 2, which says that it's possible to understand and change behavior by focusing on its consequences or the function of that behavior. So we've framed a lot of problem behaviors based on what outcomes, what consequences are maintaining that behavior. So if there's a consequence that's maintaining a problem behavior, then maybe we change that consequence. Maybe we adjust the situation so that that behavior is not maintained. We can make it too costly to keep doing the problem behavior, or we can make it less reinforcing to do that behavior. We've learned lots of different ways to adjust these consequences in order to adjust the behavior. And as I've kind of said, behavior is complex. It is quite a bit easier to try and understand and change or modify individual components. If we break it down into its constituent parts, it's a lot easier to approach. But behavior as a whole is complex, so we do always encounter situations where we think we know what's going to happen, but that's not quite how it works. But at least we now have some framework to approach different behaviors, and hopefully you found it as interesting as I did.